It's 11:11. Make a wish.
And it not affect the shot?
I think the issue is that, so we could maybe scooch the couch.
Do you want to
painting.
just scooch the couch?
I think we should scooch it like
Yeah.
a teeny bit.
I can scooch this whole thing.
Don't, nope.
I know, but
no,
you're at the edge of the
No,
rug.
you stay. You do not move, ma'am.
Y'all are so funny.
Welcome to a special episode of the Hacking Hypermobility podcast.
I'm Luna,
And I'm Shelli.
and we're two bendy mamas.
Hacking Hypermobility.
And our producer, Tiffany, is going to get us started.
Today, we are so excited to have the opportunity to talk to Dr. Tina J. Wang. Dr. Wang is a board-certified physician in physical medicine rehabilitation with over 15 years' experience in musculoskeletal medicine, rehabilitation, and performing arts medicine. She is a clinician researcher, university professor, scientific author, and founder of a clinic dedicated to the care of individuals with hypermobility disorders. Dr. Wang currently serves as assistant professor of physical medicine and rehabilitation at both Loma Linda University School of Medicine and the University of California, Riverside, where she is core faculty for the musculoskeletal curriculum with a focus on imaging-based diagnostic and interventional procedures. Her research centers on fascia and hypermobility spectrum disorders, Ehlers-Danlos Syndrome, just EDS, with published work investigating the ultrasound characteristics of fascia in these conditions. She is an active fascia researcher and serves as vice president and board member of the Fascia Research Society. Dr. Wang is also the founder of the Hypermobility Professionals Consortium, an interdisciplinary network of clinicians and researchers focused on advancing care and knowledge in hypermobility-related disorders.
She is
girl.
a Renaissance zebra. Hi, Dr. Wang. It is such a pleasure to have you here on the show and to get to chat with you again. So for listeners, we met last summer when you taught a fascia workshop at the EDS Society's Global Learning Conference in Philadelphia. And you and Jeannie DeBond taught us about fascial breath. And it was an interdisciplinary room. So it was providers that are interested in EDS and it was patients. And it was such a warm collective experience that we all had in that room with you all. And for me, it was the first experience where I truly experienced breath work resetting some pain. And when I released, I laughed, and there was a doctor sitting next to me who had experienced the same thing. So it was like a typical connective tissue person and an atypical connective tissue person. And later on in the conference, I got to talk to you about your work because I'm such a nerd. I love the science and the research. So that's why I love your work, because you're behind the scenes leading incredible research about this, but then also clinical application treating us. And we had such great conversations about the intersectionality of disability and racism, representation within research and the zebra community, and aspects of neurodivergence, and just the deeper meaning of your work. I knew when then I couldn't stop talking to you, we had to have you on the show. So I'm thrilled to have the opportunity to get to talk to you about your work on the podcast and just to share your work more widely with the audience, because I think it's so important for the community. So thank you for taking your time away from your patients and your research and life to sit down with Hacking Hypermobility.
So I hadn't really heard of fascia before until recently. So what led you to specialize in fascia science and hypermobility disorders like Ehlers-Danlos syndromes, EDS, and the hypermobility spectrum disorders, HSD?
Yeah. Long story. So I'll try to keep it less than an hour.
You can give us as much as you would like, whatever you feel like sharing.
Go down the rabbit hole.
Yeah. So I started life out as a dancer.
Hey.
And us dancers have a lot of quirks. A lot of us are hypermobile. And when our joints sublux or dislocate, we teach each other how to relocate our joints. It's just a skill set you learn, and it just is. You didn't ask, why does my body do this? It's just like, well, yeah, of course the navicular drops out. Just do this. It'll go back in. Yeah, your kneecap dislocated. Just shove it back in. Hurts a little, whatever, you'll be fine.
By the fifth time, it's like...
Yeah, you just do it. And we taught each other how to take care of our bodies, how to condition our bodies, how to take care of them. And as I went through medicine, started out as a performing arts medicine specialist. So treating dancers, musicians. I was also a musician. I can't say I am because I am. That would be overkill to say that I'm a great musician.
What instrument? I could play the saxophone sort of, but not the trumpet. Like I couldn't. I'm just being nosy. I'm sorry.
Yeah, I play the violin and the piano. And then I dabble in the guitar and the ukulele, but a musician would argue with me that I'm actually playing anything. And yeah. So as I went through medical school and additional training, hypermobility was unavoidable. So in the musician population, there are high rates of HSD, hypermobility spectrum disorder. And then in dancers, there's high rates of generalized hypermobility, of EDS and HSD. And so it was not something that I could ignore. And in those early days, the classification was still controversial. We were still all in different camps and arguing if generalized hypermobility with asymptomatic itself conferred any risk factors. Those were still the early days. And a lot of the early literature came out of the performing arts medicine literature as well. And so that was the environment that I was training in. And these were the questions that we were grappling with clinically: injury prevention, injury occurrence, which is a big deal, and conditioning. And then along the same time, I trained as a physical medicine and rehabilitation specialist. Myofascial pain syndromes are a big part of that specialty. It's a big part of the patient population we treat. Musculoskeletal pain, joint pain, neuropathic pain, phantom limb pain, and amputees. So a lot of pain treatment. And I am one of those people who follows all of their outcomes. So I follow all the patients. And so there is no telling yourself that you're great or, what does the literature say and what is your outcome? And what I found was that Western medicine, allopathic medicine, and their outcomes in terms of the treatment of myofascial pain, musculoskeletal pain is abysmal. So it's not your doctor, it's the tools your doctors have and the tools modern science has. It's terrible. And the outcomes are terrible. So that led me down this pathway of studying different approaches, studying different techniques, studying the literature, what is out there, what resonates with patients, what's true, what's observable. And so here I am with a large population of hypermobility and still also trying to understand myofascial pain and how to treat it. And eventually, really not eventually, I think the entire way the worlds all coincided. Even now, they'll tell you, a lot of the folks who treat chronic pain will tell you it's like an entire clinic of hypermobility. We just call it pain.
That's fascinating. I didn't realize that we were so much the majority in pain clinics.
So you're writing a book about these topics. Is there anything that you can share with us about it?
Yeah. The textbook is more, so it's with Handspring Publishing. They've been purchased by Jessica Knightley. So that will be coming out in the next, I'm hoping by the end of the year. You had linked a great, let me see if I can pull it up, the title.
The study?
Because not the study,
Dr. Chopra from April.
It's
the study.
Yeah, she pulled up the study. Yeah, that was great. So I read that from what she pulled up. She's fantastic. The title of the textbook itself is really long, and they wanted to go with the boring title. Yeah. So it's Fascia Hypermobility Disorders: Structural, Functional, and Innovative Diagnostic and Therapeutic Approaches. So a lot of it, a bit of it is, publisher helped me come up with that, and they are quite an editor. And they chose the very specific long title. And a lot of it is, I don't know. I can't.
That's why we ask book editors.
See, that's what I would call it.
Fucking
People would be
fascia
People would be like,
is what I would call it.
sorry. So publisher, editor.
So yeah, they're the experts, and I like the long, boring one. I just was surprised that they wanted the long,
But they
boring one.
We're so specific and long. Yeah.
Yeah,
Yeah,
the
yeah.
world seems to like quick. Ooh,
Yeah.
let me.
So is this geared more towards patients or providers, or is it
Ooh, that's
both?
Oh, they're such a great publisher. They really know this field well, and they really publish their array of books are really geared towards all levels of readers,
That's exciting.
practitioners,
Well, I know
patients,
what I'm going to ask
family.
for Christmas. So
You know, I like to send random gifts to people.
yes, I had a question from a listener, and I just said, "Hey, I'm talking to a fascia specialist. What would you like to know?" And the first question I got is, "What is the difference between terms we hear like fascia, collagen, connective tissue? What are we talking about?"
Yeah, so that is a very common question that I get, and I will define them because it's actually very specific, and it's very quite scientific when we're asked these questions. So we'll start with the most reductionist part of that question is what is collagen? And collagen is a structural protein, and it makes up the connective tissue, which we'll talk about. It's one component. And there are many, many types of collagen in the body, and they are a structural protein. They fold together to make these strands, and there's 28 different types, and they have different structural components. And if they go awry in the different types, then you might get specific types, subgroups of Ehlers-Danlos syndromes. You can get osteogenesis imperfecta in the type 1s, chondrodysplasias, amongst a whole host. So we can go on and on. But it's a structural protein. The connective tissue itself is one in 4 types of tissue in the human body. So this is anatomically defined. And connective tissue is one of these 4 types, and it consists of tendons, ligaments, cartilage, bone, so on and so forth. And then when we get to fascia, which us in the Fascia Research Society and in the fascia world, we like to think of fascia as a system. And so that is also defined by the anatomists of the various types of systems, like the cardiovascular system, the immune system. And so in this case, fascia would be defined as a system. However, I will tell you that's highly controversial. So even just this morning, meeting with people in this fascia world, everybody comes from it with a very different set of definitions. So our osteopath colleagues will include blood. Our biotensegrity colleagues say that it cannot be dissected or defined in such discrete manners and has to be viewed as a whole. And our more anatomical physician colleagues will say they're discrete layers that are dissectable and permeate the body and are set in different types of layers, loose, connective tissue, dense, loose, in these multi-layered settings. So that's super controversial. And what I tell people is that it is a body-wide network that permeates every organ, every tissue, and it envelops and permeates us. It's a system on its own, and it's crucial to all our metabolic, structural, and signaling processes, and we cannot be alive without it. And our organs and our systems cannot function without it.
So the fascial system, what is its primary purpose?
It has many different purposes, and they are metabolic. So all of the metabolic active processes in the body are supported by this structure. It's also structural. It provides support, and it's also a interface and a participant in signaling processes as well.
It does everything.
It's like the glue that holds it all together.
Oh, that's okay. From Tiffany.
So we have another question about the fascia specifically. When did fascia come into play? When did that
when
become
did
a
someone
thing?
first be like, it's the fascia?
It has been around for quite some time. So wound healing is a fascial process. Yeah.
We were just kind of seeing it in micro lenses, and now we're kind of pulling out and seeing it through the macro lens as a system.
I never thought about it that
Yeah.
way.
So,
Just like I never thought about my nervous system
yeah.
before.
So last year at the Global Learning Conference that the EDS Society did, one of the things that you said that like I wrote down and I was like, I want to ask you about this, was that you said hypermobile Ehlers-Danlos syndrome is a fascia-based disorder. And you said that there are even differences at the cellular level and within the extracellular matrix. Can you explain what your research found in these differences and what you've seen?
Yeah. So the fascia itself, when we get down to these more microscopic levels, it's composed of the extracellular matrix. And extracellular matrix is everything that is outside of the cell, the fibroblast. So when you ask that question, when did we figure out this fascia is important? Well, the fibroblast and its importance in wound healing and immune as an immune cell
Like it's the gatekeeper.
participant. Yeah. This really happened 60s, 70s, and it continues to evolve, and using extracellular matrix in regenerative medicine and studying its regenerative properties. These are really important. And it's in this extracellular matrix outside of the fibroblasts that a lot of signaling can occur. And in hypermobility spectrum disorders, HSD and HEDS in particular, hypermobility type, the Colombi group out of Italy found that the extracellular matrix is in disarray and there is abnormal myofibroblast signaling.
So it's visually different when it's imaged.
And so they did a biopsy. So my study then I wanted to see then at a more macroscopic level, if I image this ultrasound, will it be different? And Antonio Stecco's work, not in hypermobility, but in people with myofascial neck pain headaches, showed that there were differences. And so that's what I found in the EDS population, is that this process there is abnormal aggregation of the extracellular matrix of that fascial tissue.
That's fascinating. Is that something that's clinically applicable and available yet, or is this just in research that would be doing this type of imaging?
I do it clinically, so I will look at patients and take a look to see if it's supportive, especially if it's unclear or the patient's really questioning.
Interesting.
I will image these select areas that have been researched to see. And then I'll also follow patients clinically that way too.
So also you've talked about recently, you posted something where you talked about how fascia in hypermobile humans is sticky. Can you break that down in lay terms for listeners?
Yeah, so this extracellular matrix throughout the body is then thicker. And what happens is when we change the property that way, there isn't a glide. So in this deep fascia, there's layers of dense tissue, loose tissue, dense tissue, and this sandwiching allows a glide to occur. So this glide then allows for proper force transmission, dispersion of forces. So you can imagine when it's gooey, thickened, and sticky, it doesn't glide so well. And it forms then, it's like a MDF particle board. Right? That stuff is really strong. Yeah, super strong. So now instead of a dispersion of force and this proper glide, first your muscle has to contract really hard to get the force going.
This is making so much sense to me right now.
And as you're explaining it, it's like you're naming sensations in our bodies.
Yeah. And then when you you're trying to get this motion going, and you have to contract really hard to get, and there's proprioceptive deficits, right? So you don't even know how hard to contract, and then you don't have this proper force dispersion, so it goes right to that kneecap, and then there it
And then
goes,
you
popping
sublux
right
your
out.
thumb and have to wear a brace because I didn't know how hard I was.
So this tissue is what's giving signals about proprioception, or where our body parts are in space, is what you're saying?
Quite a bit of it, yeah. At the thickened bands, the retinaculums, lots of proprioceptive nerve endings. And in this population, you can imagine if it's an aggregate, a densification of the extracellular matrix in these areas, then there'll be irritation of nerve endings. Proprioceptive signals will be disturbed, and so then we run into walls, we fall for no reason, can't stand up
Upstairs.
straight. Yep.
So I have a theory, and this is just a theory from my personal lived experience and just kind of some things I've read in the science. I don't know if you've delved much into lipedema, but it's a fat disorder common in EDS. Again, it's something I was diagnosed with late in life. And it almost seems like that same thickening is happening in lipedema. We get these fat nodules, these hard nodules that don't go away with the traditional ways of getting rid of excess body fat. And it's almost like that's modulated in the same ways. It's coming from kind of some similar mechanisms. Have you looked into that at all, or are you familiar at all?
Yeah.
That's a great question.
I just finished a study with Claire Francomano, Wendy Wagner, and it's in review for publication right now. So we looked at fascial changes in people with EDS alone versus EDS and co-occurring lipedema. And so what we found was that
Did you know that? That is crazy. That's awesome.
Well, kudos to Wendy. So Wendy lives with EDS, and she had called me up and said, "I'm so frustrated. Nobody's studying this." Said, "Okay, I'm not into this lipedema thing, but sure." And she said, "Well, I'm going to get Claire Francomano on this, and let's do it."
Who
I said,
better?
"Okay."
I mean, let me just
Yeah.
give Claire a call. You can imagine.
I cannot wait. Will you send that to me when you publish?
Yeah. Well, hopefully it gets accepted and we can get that out soon. And so now I know a ton and I feel comfortable diagnosing. And basically what we found is so we may or may not call that the superficial fascia, but it's the lipid layer, and the superficial fascia proper runs in there, but there's connective tissue in there. And so let's say we call that the superficial fascia, that adipose layer. So that is thickened in lipedema a lot. And that's not novel research. There's a couple of paper in the Amato study.
Yeah, there's some papers linking it to mast cells and everything too, which makes perfect sense if you know about all our comorbidities. Before we move on to the next question, this was spur of the moment. It happened when we were talking about it, so I kind of derailed a little. I'm going to show viewers what lipedema looks like just briefly. If you have like these weird fat deposits and they're like hard and lumpy and they hurt, a lot of us not everybody is, but a lot of us experience the fat deposits, is particularly in our lower limbs first.
Saddlebags.
And you'll have a like distinct cuff around your ankle. I have really skinny feet, but like it's strange. There's a cuff and then there's a fat deposit around my lower legs, and it hurts. It hurts so bad. And once I got diagnosed, I realized that was the majority of my pain was related to lipedema swelling. And there are things we can do. And there's actually a lipedema standard.
Like a protocol.
There is a protocol, and I can link that later in the show notes if you're listening and you want to learn about lipedema. So let's go back to fascia. I think Tiffany has a question.
Well, I can tell you that in that study, we found that the deep fascial densification is actually amplified in lipedema, so that you get both layers that are thickened. And there was a correlation with the thickening with the presence of immune dysfunction, aka mast cell.
Yeah.
So the study really supported that and corroborated that, which I'm always surprised to find out when study findings actually corroborate.
When you can replicate.
Yeah. And the lived experience, because usually we we make a hypothesis, but it may not pan out. And then your study's not publishable. It's great.
Right. Well, because there's, we have as patients or someone living in these bodies, we have ideas and theories, but that's not the scientific method, right? So
No, it
we can-
is. It is. I
But-
argue that it is. That's how I
I mean, I
started
guess if
doing
we actually
research.
documented throughout the day what we think,
Yes. But if we listen to our intuition more to guide research, I think that would be so exciting. So that's why I just love that researchers, you three came together to tackle this project with your own individual specialties and knowledge to like, okay, let's look at this. We think there's something here. It's important. No one's looking at this. I'm thrilled.
Yeah, it was that's how all of my EDS research is done is I have a question and I want someone else to do it and they refuse to.
I have this great idea. You know what? That is a great idea. Go ahead and go for it. Let me know if you need help.
What's that?
But not really. I'm busy.
Fine, I'll do it myself.
All right, Tiffany, what you got?
So I have a question still on research. What has your research shown exploring the differences in the fascia between people with EDS or HSD patients versus an unaffected person? Like, how do you see those differences? What does it look like from your side?
Yeah, so people without HSD EDS will not have this densification. Their fascia will have a normality. And so the Stecco lab with Carla Stecco, Carmelo Puri, they put out a lot of normal standards. And I'm on a task force where we're trying to work towards ultrasound of fascia. Got a long way to go, but we're looking for standards and normals.
Mhm.
And then you have this densification in EDS and HSD. And in our asymptomatic hypermobile population, this densification is not there. But it is there in non-hypermobile people with pain, but not to the degree that it is in HSD EDS.
So it almost makes you think the pain is what's modulating these
So you do see patients that don't have a hypermobility disorder. They have
pain.
the pain related to the fascia, but it's not HSD or EDS
So
related.
when we talk about our pain being in our tissues, this is where it is. And also, you're talking about taking ultrasound imaging and seeing our disordered fascia. And I just had a realization. We talk all the time about this being an invisible disability. This can be a visible disability.
I have a question when you're done with that.
Hey,
Okay,
You just like that. I broke my
So
brain.
we're all of a certain age. I don't know how old you are, Dr. Wang, but I started having mammograms when I was 38 because I felt something and they categorized my breasts as like super lumpy, blah, blah, blah. And I was wondering, that's fascia or lumpy breasts?
so
They told me I
it's
had dense,
adipose
fibrous
tissue.
breasts.
Yeah,
They-
it's super common.
Yeah.
Okay.
In mine, it was the opposite. I
Oh.
carry the breast cancer genes. So
I have some
started
too.
early. And so they were kind of expecting, but no, they said, no, we can see EDS in your breast tissue. It's so stretched.
So yours are stretchy and mine are just hard and lumpy.
This is embarrassing. Yeah,
What-
but yeah, they're
We
stretched
can
out.
cut it if you
I
want
mean,
to.
I know they're stretched out. I didn't need you to tell me.
Well, hey,
I was just wondering because
I-
they have like those categories, and I was like, oh, is this because my fascia is different? Like I'm like a number 3, like I don't remember what the number is, but they were like, because of this, it might be harder for you to find
For them
lumps.
to
But I also,
to-
the lump that I found was actually like an amyloid, like a tiny amyloid, like a little cysty thing.
Well,
I
that's
don't know.
good.
yeah,
Yeah, that
this
was
is-
great, but it just made me wonder.
Yeah, this is such a great question because it really is one of the most frustrating things about EDS is that it manifests phenotypically very differently and every individual and every system is affected differently in each unique individual. So unless you're looking at pathophysiology and really understanding it from a holistic approach, then you're just saying, no, these people are nuts. It's all in their head. You can't have this many diseases and
Look
it
at all
can't
these
look this
specialists you go to,
different.
and they can't find a thing.
Yeah. So not only is it phenotypically different, but even like within families, my own daughter experiences symptoms differently than myself.
Same. Carolyn gets far more migraines than I do.
So I have
Yeah,
a question then. On that note, do you think your research might help shift the diagnostic lens away from psychiatric mislabels and expensive genetic testing and towards fascial imaging or biomarkers?
That's far less expensive and invasive.
it's I hope it's too early to say. And so even with one of my papers that I have sitting here on my desktop, awaiting revision to send back to the reviewers, is that question. So if we're going to use it diagnostically, then how does it look like in comparison to mimicking conditions? Is it reproducible? So your prior question is who's using it clinically? Well, please use it clinically, and then you can do a study and tell me I'm wrong.
Mm-hmm.
And that conversation needs to happen. And that's some of the hardest parts of this type of research, is that we need it to be translatable and clinically applied, and people to tell us we're wrong or we're right. And that's where it has to go first before widespread adoption. Even the recognition of the diagnoses itself has been really challenging over the last 10 years.
Yeah.
Yes. So I'm thankful that there is research where people are asking these right questions, or the questions that we as patients need. That's so reassuring, one. And then you've got me thinking now, how does fascia affect the common comorbidities that EDS HSD patients experience? Like we mentioned pain disorders, but MCAS, dysautonomias like POTS, etc.
Yeah, the fibroblast itself in the connective tissue are themselves immune cells. So they have direct communication and response to the immune system. So when there's an injury, let's say, and the fibroblasts are signal, you get an ankle sprain, then there is immune signaling from the fibroblasts to bring in immune cells to start to clear out the tissue, repair the tissue. In addition, there are rich autonomic nerves in there. So if this whole process is occurring, then the autonomic nervous system is affected too.
Mm-hmm.
You can think about it through those systems as injury. So the autonomic nerves are stimulated. You have some kind of psychological trauma,
Mm-hmm.
or blood pressure drops, blood pressure raises, then the immune cells are signal, the fibroblasts are signal. And so through these mechanisms, you can see that you might have an injury and the immune system is activated.
Mm-hmm.
And the cardiovascular system and autonomic nervous system are activated. So you sprain your ankle and you're now feeling like you're insane, screaming at everybody, and then passing out. And then you have massive reaction to everything you put on your skin, eat, and touch. Everybody thinks you're insane, and it was an ankle sprain. And you take care of the ankle sprain and everything calms down. Or you eat something wrong and then they tell you it's all in your head and your whole body hurts, is inflamed, your joints are way looser.
It almost seems like I personally have either a very intense overreaction or a very
Delayed
underreaction. So sometimes, like I have an incredibly high tolerance for pain. I broke bones as a child and never knew. But then sometimes I'm hypersensitive and I will I'm immediately dysregulated, like what you were talking about. It like swings in opposite directions. So even within the same body, we're unpredictable.
I'll even have the same trigger affect me differently.
And now you were talking about like how, we may have a stressful situation and our body responds in a certain way. Being a lived experience show, when we talk about our own lives and that sort of thing.
A lot.
When you
too much.
said that, something came up for me and I wanted to share it with our listeners. And this morning when we talked to Jeannie DeBon, she shared how she went through a very difficult time in life. And that's led to her devolving in her physical condition and getting diagnosed. And I went through something very similar at middle age. I went through a couple of very intense traumas. And all of a sudden I was dealing with these crazy allergies that I never had before. I was constantly swollen. I spiraled into severe MCAS. And at the same time, I was also having very intense pot symptoms. I was very physically active. I was swimming an
So
hour.
weightlifting. Too, right?
I was powerlifting. I was swimming an hour a day. And then all of a sudden I couldn't walk a mile. And it was in the pandemic also, of course. So that was fun. But just as an example, so like, you know, it can be a little thing, but then also many of us, when we go through something very difficult, you are not crazy if your body spirals along with your emotions. And that's what you explained. And that's why it's, you know, our sensory organ, it's what's connecting us to the world, right? So now that I said all that, that's also the time that I sought psychiatric care because I was so burnt out. And I was diagnosed ADHD as a child. So that should tell you how bad I was because it was the 90s and I'm a girl. But they missed something vital. I finally went for testing, like, you know, we sought mental health care. I went to trauma therapy. And the trauma therapist, I failed what's called EMDR, which is a type of trauma therapy. And she was like, I think you need to go see a psychiatric specialist first. And she kind of soft launched the idea that I might be autistic to me. And I was like, pish posh, no, I'm not, because of stereotypes and that sort of thing. Long story short, I also I was diagnosed with EDS. And then I was shortly, like a year or two later, diagnosed with autism. And then I found out they were connected. And I was so mad at the world.
That makes me happy that all of mine came within like 4 months of each other.
I was like, what do you mean? We know it's connected. So one of my questions now is, well, how does this work? So how does fascia as this connective tissue, the sensory organ, interplay with our neurodevelopmental differences that many zebras experience, such as ADHD and
hip checking counters all the time? Get rounded corners on your counters, people.
Is the fascia part of the connection?
So yeah, I think that it can't be discounted. And in the studies where they're looking at rates of hypermobility, there seems to be a correlation. So it's probably not a causation if we're saying outside of hypermobility and the conditions itself, but there seems to be a predisposition if there is connective tissue abnormalities, hypermobility disorders, that there is very, very, and that's what the study shows, very high rates of neurodivergence. So dyspraxia, left-right differences, OCD type behavior, right? If I can't control my body, if I can't control my environment, I'm going to try to, something.
Yep.
And
Why do I
also the connective tissue, the brain is all our organs are consist of connective tissue and fascia. So you can't separate that. And Mary Mastery, she does amazing work with pediatric rehab, and she has a theory of the developmental of this neurologic patterning from children with abdominal issues. When we dig deep into these history, and the literature will show you too, in autism, digestive issues are really rampant. And so if
some of the first signs in me and my daughter, for sure.
Yeah. And these, and that's why I argue in the beginning when you said it's an invisible illness. It's not invisible. It's just, you just
got to know what you're looking for.
Yes. And it's subtle, but it's present. It's very present. Yeah.
Now that I know it, I'll see people and I'm like, yo, I hope you get some help. In a nice way.
And it also, I realize now it's not that rare because I see it all the time.
But is that effect, the Dunning-Kruger effect?
Yeah, maybe. Maybe it's because I know.
Like when you're pregnant and then all of a sudden everybody's pregnant? Maybe.
Who knows? But do we want to take a stretch break real quick?
I need to pee.
Yes, we need a quick potty.
I need
to stretch my tailbone.
Yeah, go crack the things and... Sorry, ma'am. I should have let you get up first. I'm so sorry.
I'm slow.
You ran over her.
Because I'm about to pee my pants.
Hey, if you sprinkle when you tinkle, please be neat and wipe the seat. Also, I love having a bidet, and I like to keep a pulse oximeter next to the toilet for those unexpected dysautonomia barf sessions in the middle of the night. Okay, back to Dr. Wang.
Dr. Wang, you've studied treatments like Botox, hydromanipulation, hydrodissection, prolotherapy, and even cannabinoids, my favorites. Which of those are showing the most promise right now?
Yeah, I wish I could say there's a slam dunk treatment. There's no, you have to see what your body needs, what your body wants, what your body can tolerate. The order matters, the timing matters, all of that.
Awesome. I didn't expect that, but I
Expected that they're
it's
one
as all one
right?
size, yeah, one size does not fit all. So
Yeah.
along those lines, me personally, I sometimes, especially in the coat hanger area, if I also get regular massage, so this may not be necessarily me specific, but when should someone seek a specialist or a massage therapist or a knowledgeable person to help them with some tight fascia that they can't work out themselves? Like, I have a bunch of things I try at home, but like my youngest, who has basically, it feels like rocks under their skin and their back, doesn't necessarily like to be touched and has sensory issues with like using my hot tub to help relax some of that. So like, what can I do, and how long should I let that, like, how concerned should I be about that for them? Because they are not
Oh,
generally a
yeah.
happy camper. Yeah, that's a really lot. I'm sorry.
So, no, it's not, because
Yeah.
I have a kiddo too, and I'll tell you, my colleagues think I'm nuts because I'll watch him move and I'll see something.
Yeah.
And then because it's me, so I'm not a mean awful person. It's just I'm really intense, and so they'll feel like they're not qualified. So then I'm left to try to figure it out on my own, which means now I have to take more courses. So I'm constantly taking courses and learning,
Right.
so I can problem solve for my own kiddo. Because I would say, and that's one of my passions, is how do we prevent things
Yeah. Like,
rather
how can we
than
prevent my child's back from becoming like rocks are under their skin?
Yeah. We
You know,
want
yeah,
we want to
yeah,
slow
and
down what they're experiencing so they don't
They're
get
not-
to like what we've done.
they're going to be 20 in September. They're 19 years old. That's not cool.
I would definitely, I am a big proponent of modification. So modifying that phenotypic expression. So even at a tiny young age, it's not too early to start making sure they're eating properly, figuring out their food allergies, joint instability, if they need some manual therapy, if they need some professional help, mentally, physically, whatever it is. Intervention at a young age is not too early. That being said, I also recognize resources are an issue.
Yeah.
There was one time I thought, oh gosh, I'm so glad that I know how to do XYZ, because gosh, it costs so much money if I had to take my kiddo or myself over. And then
Yeah.
I calculated how much it cost me to learn how to do XYZ.
It's probably less.
It didn't add
Well,
up. It didn't add up.
the cost benefit analysis in the long term
I love that she did the cost analysis.
sorry.
No, it is funny because I
You are
really
my
did.
people.
Yeah, I was like, wow, I'm so lucky. No, I'm not, because I could have just paid for a lifetime of treatment.
Now I'm thinking I want to add up all the time I spend reading medical research so that I can tell my doctor
What your diagnosis is?
what they probably need to diagnose me with and how they need to treat me because they don't
Mhm.
know the answer.
Yeah, and that's a big part of it, is intervention at a young age. So asking my kiddo, what do they need? It does require a lot of education for yourself and getting the kiddos to learn how to learning how to learn and
Yeah.
communicate their
And
needs and
advocate.
setting the
Yeah.
boundary.
And
Yeah,
advocating for
advocacy.
themselves.
We
Yeah,
cannot
in a way that
that.
helps them be heard in a productive way. Because I see patients do it so well, and I've seen patients do it so terribly,
Yeah.
and it really affects their care.
That's probably a skill
That
we
takes
need to teach
practice.
patients. I would love to see a workshop or something like that where we can learn
do a role-playing.
self-advocacy. We got to talk to a patient advocate, like a professional that you can hire. So I know like there's those resources for us, but not everyone can manage that. So it would be great to see someone that has the skills to maybe teach
Yeah.
that to us. Yeah.
So thank you for that answer, by the way, because I know me with my issues and then seeking care for my own child who was much younger when I actually started thinking something was going on. A lot of people who weren't necessarily in the know thought I was being a hypochondriac. You just want her to have the same thing you have. I'm just trying to help my kid feel good. Anyway, so along those same lines, do you have any resources or knowledge about an accessible fascia-friendly exercise regimen that you would recommend? Or are you going to send us to Jeannie? Because I think Jeannie's a really great resource. But do you know of any like specific fascia along
Darn
beside?
it, you stole my thunder. I always
Sorry,
say just go to
we can cut
Jeannie.
that. We can cut it. And do you know of any resources that have a fascia friendly exercise regimen that you would recommend for someone with HADS or HSP?
Dude, oh my goodness, do not cut that. Do not cut that. No, I have additional answers, but Jeannie is my go-to because
Right.
she takes all of that into consideration. So if you have cost concerns, she's got a program for you. If you want more one-on-one, she's right there for you. There are so many resources. So I tell people there's 3 prongs to treatment. One is manual therapy, and that can look like anything. So if you don't want to be touched, that might look like rolling things out, stretching, something like that. The other, or a weighted blanket because you have autism, right? Compression garments. That itself is a manipulation.
Wearing it right
Then
now.
I've
there,
experimented with vibration and
ooh,
TENS units and that sort of stuff.
I have a TENS unit. Oh, I'll bring that down for us to play with. I have a TENS unit
yeah,
too.
I love modalities because, and I was taught to hate modalities, right? So teach the patient to move. Okay, so that's the second component. But modalities are great because now they're not spending tons of money seeing someone. They have the units, they know when to use it, how to use it, and
I took
then
mine to my
the
PT and they taught me how to use it.
that's where the money can be spent is, okay, show me when I can use it, how to use it. And then the second component is movement. So movement also doesn't have to be ridiculously expensive. Now, if you're really in bad shape, yeah, you kind of have to go to a physio to really put yourself back together. Depending on your functional status and your stability status, movement is really important. And then the last component is your medical team, which also includes alternative medical practitioners. So if you don't like your doctor, you don't want to see your doctor too much, they're good enough for whatever emergencies, okay, then see your herbalist, see your acupuncturist, your chiropractor, whoever you trust to handle the everyday or the chronic and keep the specialists for acute problems that have to be addressed. So these are ways to start to self-manage this 3-pronged approach, and all these components have to be present. In terms of if we're talking about the most accessible fascial-based movement conditioning practice, Jeannie is definitely an amazing resource. If you're looking at your younger kiddos, I had my kiddo in jujitsu. Yes, it's contact, but it's a lot of functional movement.
Yeah, it's like all
And
of the
so,
forms, right? My kids did taekwondo for a while until they got
yeah,
they didn't like the combative part because then they got too bruised. But before that part was great.
right. Yeah, the fundamental movement patterns,
Mm-hmm.
because a lot of us may have skipped stages in development, or it did not develop
Accommodated
properly,
in the
or
wrong ways.
and then we have these dystonic patterns or these proprioceptive deficits that need constant retraining. So dance is super protective. There is a study in children, and the dancers' dance was protective. And so I strongly believe all these years of dance training help keep me intact.
I think peoples before us knew that dance was healing.
Dance is an integrative part. It's in all cultures as like a
Yeah, it's a communal healing kind of experience and an art form. So, okay, so the three approaches are the
modality.
movement therapy was the one we were just movement was the one we were just talking about. Manual therapy. What's the third?
And your medical team.
They're all M's, right?
Medical. Yeah.
Or did
M.
my working memory fail me on that?
No, you got it. Those are M's. We can make those M's, right?
Awesome.
Question. So you're a board member of the Fascia Research Society. Can you tell us some highlights about the efforts and outcomes?
Yeah, I'm really super excited to be a part of this amazing society. It was founded by Tom Finley. He was a PM&R doc, and his passion was really treating myofascial pain syndromes and understanding fascia's role in all of this and bringing together these different types of modalities and practitioners so that we could study and learn from each other. And that is the work of the FRS, is how do we bring together these voices in different fields so that we can work collaboratively and make groundbreaking changes in clinical and bench science research. It sounds really lofty, and it really is. It's really hard to get people from different backgrounds to work together. You put a, yeah. Yeah,
So is your group seeking additional collaborators, or is this like a growing body, or how does that work?
Are there chapters?
So right now we are really laying the groundwork for the collaboration. So previously it grew organically. And now over the years, we're seeing that we really need to implement strategies to really formalize these collaborative efforts. So we're always looking for experts in all different fields who want to come in and start to collaborate. So we've started task force, interest groups. We're going to start mentoring groups, and we definitely have a lot of education. And so it's out of these previously organic groups that research has grown. And I would say that now that we're trying to formalize things a little bit, act as the glue, act as the fascia, that we're hoping that really solid work will start to come out in the next few years.
That's fascinating. Sorry.
You're so funny.
I can't help it. No, but really it is. Like, I love that we are connecting things together to work. But like that was like
Love
she
you.
said that.
I know I love you. I'm just keep
Yeah.
the joke going. I love it.
I want to reflect that I love the puns. I love the jokes. And just even what you had said about the patient perspective and lived experience driving research, right? Even that little thing is like asking so much. Why is that so hard? And that is so reflective of what we're trying to do at the Fascia Research Society, is to bring people together rather being scared of differing voices. What arises out of this willingness to communicate and collaborate?
Well, it's not very common that research takes into account patients' voices unless the researchers are the patient, which is so often the case in research in the field, but often it's not. So I love that you guys are taking all these different experiences, ways of different providers approach things differently depending on where they were trained, their experience, their the type of patients they've come, that sort of thing. So what do you think is some of the most exciting research that these different groups of people are interested in looking at?
You mean in terms of hypermobility or in terms of
Or fascia.
fascia? I think some of the really, really exciting stuff are looking at biomarkers. If we can get biomarkers out, even if it's not a single one, even if we have, let's say 5, and we're saying if we run 5 and this many are positive, and we marry that with imaging and symptomatology, then we can really influence sensitivity and specificity for this
Actually have
diagnosis.
all the information.
Yeah. And then it's hard to even like talk about sensitivity, specificity when we have a loose clinical diagnosis without a gold standard. So that's where I really want to see is everybody come together and let's have a clear diagnostic standard.
Clear this up.
Yeah. And I think that's what they tried to do in 2017. But again, it's, we can talk about it like it's so easy.
We did a whole episode on that. Or series.
Yeah.
Super difficult, a tall task.
I think until
when so much of the care is
there's still
case
not
by
enough,
case.
Yeah. And there's not
how could the diagnostic be
there's not enough big research to really define it truly. And I mean, that's part of the frustration and part of the reason why we go undiagnosed.
Earlier, you had mentioned the study that just came
Mhm.
out in April.
Yeah.
The one by Dr. Lee and Dr. Chopra that shows that 95% of HEDS patients were misdiagnosed with a psychiatric disorder. Dr. Wang, what changes would you like to see in how the medical system screens and supports hypermobile patients?
Yeah, I hear Alan Hakim talk about this a lot. He's the medical director of the Ehlers-Danlos Society. It's incredibly frustrating. I teach resident physicians. That is not how we train resident physicians. It's not how we train physicians. The answer is not anxiety or you made this up
You want
or,
attention, Munchausen.
right. And that's what the article said was that 95% plus have been accused of this by a non-psychiatric professional. So it's not using a DSM
No, so they
diagnostic
were
criteria.
number one diagnosed with things like factitious disorder, conversion disorder, Munchausen. Basically, you're making this up disorder by doctors, but they were not board certified in psychiatry. They
Yeah,
weren't
it's
qualified necessarily to make that determination.
and I will be the first to say that's not how I was trained. That's not how I train the next generation of physicians.
Well said
And
for you.
yeah, in no way is that okay. And really how back when I was younger, there was a book that came out, I think it was called How Physicians Think. And it really talks about Bayesian statistics. So we have a population and we have the variables, and in an imperfect world, how do we make a probability type estimate for these differential diagnoses on what someone can have? And we work through actual math, and we know the sensitivities and specificities of tests, and as we work through these. And so this is how I train my residents. And even if there is not a clear sensitivity specificity, I'm asking them to make an educated estimate based on the literature that's out there. And then there's also clinical art that comes into there. And I have yet to have on my differential diagnosis when I'm working through a complex patients with residents, anxiety, conversion disorder. It's not on there. If you don't know, then you have to revisit, you refer, or you start to read more for additional workup, read more about your patient's symptoms, see what else can be added to the differential diagnosis. But conversion disorder is not on there.
I think honestly, it's a cop out.
Yeah, it's like, I'm not sure, but I need to tell you something.
Yeah, or I don't want to do the work to ask more questions.
I think either would be the proper answer. You don't have to say it like that.
Right. Yeah.
You just say, look, I don't know. Let me refer you to a different specialist. Perhaps these are avenues you can look into or they can look into based on their expertise. Or the classic one where I don't want to do the EDS diagnosis. Hey,
Go
I
see a
think you
geneticist.
might. Yes, here you go. Here's a referral, which is a perfectly socially acceptable way of telling a patient, hey,
There's better
go
ways
see
to
this other.
communicate.
Right. Yeah. And I think it's, there's a few reasons for it. The training system for physicians is quite traumatic. And so it's hard to say if people are spiritually intact once they get through the training process. And then the self-selection of people who are not, who are quite driven in a Western type of way.
Yes.
And so it's cultural too. And it's quite a manifestation of that.
I agree. I think it's reflective of many systemic oppressions in the way we view health and wellness and many things in the Western
And
world.
even of the provider too. And that's the hardest part to say. A lot of times in our professional group, the consortium, we half joke that you spend most of the time teaching the patient how to manage the provider who also is subjected to systemic oppression.
The same, if not, and I've explained to people who've been frustrated with me, I'm like, the workload demands that are on physicians in terms of the number of the patients they have to see in a day, the hours that they have to work just to care for those patients. So when they get a complex patient and it requires research or a longer appointment, they aren't always prepared to accommodate that, or they're not prepared mentally, physically, they're exhausted.
I realized I was an exhausting patient before I realized, because I would go in and be like, blah, 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 with everything. And they're like,
it's just, a doctor's like daily life demands, but we like a lot of people aren't even aware of like the demands on resident physicians, the sheer exhaustion.
hours.
Sometimes it's nearly abusive in the
Nearly, I would say it's abusive.
the way we train doctors.
Just the ones I know, but he's a surgeon, so maybe it was the surgeon. I don't know.
Yeah. So yeah, we're all human. We're all doing the best we can. So I think it's a dismay that we are going to ask our disabled people that are highly dysregulated to find a way to regulate themselves, teach themselves high level medical literature, and
take care of their family while they're doing that too.
To ask a likely neurodivergent person to go communicate everything they've learned to a group of people who professionally tend to look down on people. It's like, jump this hurdle, then this hurdle, then this one. So I'm very appreciative. You're not the only zebra I know teaching medical students.
Thank you for that.
That you continue to impart your wisdom and teach doctors how to take a more holistic approach and consider these sorts of things differently. Many practitioners don't necessarily have an awareness of hypermobility. Maybe they aren't comfortable diagnosing, but I think, in my experience, once I've kind of trained a doctor a little, you can partner with, a primary care doctor who really is willing to be kind of help you negotiate those specialists, help you manage the daily things of life that aren't, emergencies, but your daily medicines or care and that sort of thing. But many of them may not have that understanding or resources. So I think our next question goes into this for sure.
Yeah, I was wondering, how can practitioners start incorporating awareness of fascia in their clinical thinking, even without advanced tools? And if you had any suggestions for resources or information, maybe for providers that aren't as familiar with fascia and are wanting to learn more. Do you have any thoughts on that?
Yeah, the Fascia Research Society puts out educational webinars, seminars, and then we have our Congress every 3 years. Of course, COVID threw that off. So we were a little off cycle with that and still trying to recover from the changes with COVID, like the entire society is and everyone else. And we put out a lot of resources there. As the field continues to grow, there will be more resources and materials. It is challenging right now as we try to even incorporate this into medical school curriculum and physiotherapy, allied healthcare curriculum. It is challenging, but there are a lot of us trying to do that. That is part of the work we're doing in the Fascia Research Society. In the meantime, there are great textbooks available. Carla Stecco has one, Fascial Anatomy. I have this textbook coming out on hypermobility and fascia. So there are resources out there. Robert Schleip has a couple of science-based ones that are very digestible, easy to read. And those are the initial ways to start to think about the fascial system. And as you start to practice, you'll likely, having read this material, start to experience a frame shift as you work with patients, especially our chronic pain patients.
Seeing is believing.
Yeah. So we'll put those resources in our show notes, but also I talk to providers and they ask for those, resources. So, they've gone through school for physical medicine and that sort of thing, and they don't necessarily have those narrow specific understandings. So I'm glad that there are resources specifically about fascia anatomy and the book coming out about hypermobility. That's very exciting that there's specific resources coming. Yes. So you professionally have explored fascia, both we've talked about, at a biomedical research level, but you also touched on how you've looked at this through a more holistic lens in caring for patients. So there are approaches beyond mainstream medical care, such as integrative medicine, holistic care, culturally oriented care, lifestyle medicine, self-care, complementary, and alternative medicine. You mentioned all those last year in your talk, and we've talked about some of that today. How do you see practices beyond conventional Western medicine integrating with fascia science and hypermobility care?
Yeah, it's absolutely foundational to hypermobility care. It's an entire lifestyle frame shift, even when you're well with this condition. So you're highly functional. A lot of everyday thoughts, processes revolve around caring for yourself, even when you think you don't. One of my
To sit down in
patients,
the shower, even when you feel good.
yeah, one of my patients woke up her entire life with nausea. It was just part of her life. Everything, I mean, she had to wake up at a certain time, it had to move a certain way, had to, everything revolves around this nausea in the morning. But it wasn't something she ever sought care for because whatever, it was just
What's her
me and I
normal?
have this, yeah, it's
Yeah.
my nausea.
Yeah.
And that's a lived experience with this condition. There's a lot of things we go through that we don't think anything of it. Like, yeah, my neck always hurts and this coat hanger, so what? And if I didn't go to work, if I had it, I'd never go to work.
Right.
If I didn't get out of bed, I would never get out of bed. So whatever. Anxiety, depression, if I tried to control my anxiety and never went out the door, I'd never go out the door.
Mm-hmm.
Interactions, social interactions, then I would never talk to anyone because God knows how I'll go. And our entire lives are centered around this lived experience with EDS. And the studies show that complementary alternative therapies are very supportive of this condition. And it's because I study Ayurveda, it's because they talk about holistic lifestyle support for even the well human. And so if you're not well, they have tools. And if you're well, they have tools. And if you want to feel better and your mornings are going great and you don't have the nausea, well, there's tools there to continue to support that so that we can start to really establish a lifestyle supportive system rather than chasing acute illnesses and exacerbations all the
Band-aids,
time.
band-aids,
So
band-aids.
really the shift that, I've noticed in Western medicine, we wait till something is a problem
Reactive.
and we're reactive and we treat with
The easiest thing we can find fastest to get you out of my
the
face.
most, the first line,
Sorry.
not that just that, but like, it tends to be prescriptions, right? Or, okay, just go to PT. It's very kind of narrow. Whereas what we're talking about, these different types of care, they have a different worldview. So they're looking at more like, let's build up from that foundation. And it's about your whole daily life and your whole person, but as opposed to just one little part. It's not just one joint.
Getting new windows is
Yeah.
great, but if your foundation is crumbling.
Yeah. So like when I was first told about hypermobility, it was a hip. It was a hip. It wasn't anything else.
It was a knee.
Yes.
It
and
was my knee.
My PT said, will you ask your doctor about hypermobility? I think, this is more than just because like looking at me, she's like, I'm more worried about your shoulders and I'm noticing this is everywhere and this could be a bigger thing. And I go to my primary care doctor. She's like, well, that just means your hip is hypermobile. You're fine. There's nothing. We don't need to worry about anything else. You're good. And I believed her.
Strengthen your quads. Your knee will be fine.
Right. Until
Okay.
years and years, it just got worse. But that's an example of how that perspective that you're explaining is different. What sort of, like in your own practice, what sort of techniques or non-Western medicine do you like to use as a provider?
Yeah. So I have a whole, not even book chapter, but multiple book chapters on this. Yeah, and this is the stuff that you can't quite publish outside of a textbook because if you're trying to do evidence-based literature, they want controlled trials. So it's really this holistic lifestyle frame shift. And I break it down into all the different components. And so it's really this approach of looking at the patient as a whole, as the social system, as the environmental system, as the movement loading, the exposures. And that, then the individual little interventions will then be really patient specific. So are you a devout Christian and you go to church every week? And your church community is so important to you, then we work with that. Do you have a different belief system? then we work through that. Maybe who you were. You said that you believed your doctor. So that's who you were then. So we work with that person who was then, who believes their doctor and believes in, let's fuse this, fuse that, okay. Right. And I work with patients at that level.
Yeah.
I am ready. I'm ready for a hysterectomy. Is it going to work? Let's
I don't
go
know.
through the steps. Right. But if they're ready, I'm going to
Yeah.
support them. It's not my
That's-
decision.
That's an amazing trait in a doctor, by the way. That's not common, at least in my 48 years of going to doctors. So I appreciate you for that.
But I would argue that there's no other way. How else can you treat EDS? We don't have an answer. And every patient is different. And one patient will do great with a hysterectomy, and the other will have worse organ prolapse with
Yep.
wound dehiscence.
Yeah.
So how can you do anything except walk the path with your patient and just take them as they come?
Take us in the moment, right? So we kind of have danced around this. I think one of the interesting things about our culture here, in the United States, comparatively, is that we are very out of touch with many things. But in particular, we aren't in touch with like our body, our lived experience somatically, and our intuition and our emotional selves. We're not very developed emotionally or spiritually. And there's systemic reasons why we've cut off ourselves culturally. And I've noticed as I found a community of zebras that many hypermobile people I know are not only also a type of neurodivergent, but they also have very deep spiritual practice and are deeply intuitive people, which is a striking contrast to most people we encounter in our culture. And we've had these little sidebar discussions where we've talked about the function of our connective tissue and our fascia. And when I read that fascia's structure is like a liquid crystalline matrix, and it's partially the purpose of it is to be a sensory organ. It is kind of our first input that goes up into our brains. And so it's how we start to feel, how we intuit our experience in the world, right? Do you think that organ, that system, is part of what we call human intuition?
Yeah, I get this question a lot. I'm going to give you like 3 different answers.
I love it. Dissect it.
I'm gonna start.
That question's still swirling in my brain.
Yeah, I'm gonna start with, and I'll end back here. So Carol Davis is a biotensegrity expert and a teacher and a physiotherapist and a manual therapist. And she read me a beautiful poem about light and spirit and the formation of this matrix, this material, this crystalline matrix. And it was a poem. And so when we ask these questions, it's philosophical, it's poetic. And then we can also answer in the very scientific brain. It's probably way more complex. It's this intersection of permeation of that tissue into the actual organs and the higher function, so that thoughts of memory and soul, is it only in the fascial tissue? From a scientific standpoint, probably not. It's probably combination of all of these interfaces with the central nervous system, its interface through experience, through the fascial tissue. And then there is, if we really start to dissect it down into its separate components, my colleague Amanda Castle talks about the highly sensitive person, and she is a hypermobility psychologist. She does not advertise herself because she's such a humble person, and she's written a book on HSP. And so us hypermobile people are HSPs. We are highly sensitive people, very spiritual, very connected, very sensitive to everything around us, psychologically,
Very attuned.
physically.
Yes.
Yeah. And then I'll kind of circle all the way back is in my own approaches. I absolutely believe with every fiber of my being that we are spiritual beings in a physical body.
I would say
Experiencing,
that's same.
yeah. And I don't know if we can say that the fascia as a discrete unit would be this manifestation, because I'm still exploring what is it to have in yoga terms. I'm a practitioner of yoga, a student of yoga. So when spirit meets materiality, when Purusha meets Prakriti, how can we as physical beings, spiritual beings in a physical body, humans, separate that? It is not possible.
I don't want to.
Perhaps it's all connected.
Like fascia.
Yeah. And circling back, one of the first things I talked about was when we met, and in that movement class, it was you and Jeannie, the two sides of the same coin. And afterwards, some of us that had never met and experienced that moment together, it was a spiritual moment. All of us expressed it as that. And not only that, was it like we all had this pain release, it was like an emotional release, but then also we all ended up in this state of, we call it the flow state or whatever, when you're talking about an individual flow state. But we all were like articulated, this was a spiritual moment, but we also connected. Like this was a flow state amongst people in the room where we all experienced this release. And then in that space of not feeling pain, of feeling highly regulated, we were able to connect better. We made relationships. We made connections and networked and found people that were great resources, or I could teach you this, you could teach me this. And some of us still talk to this day.
I just had an epiphany and I'll share it after you.
Yeah. So it was like, I think we were all meant to be in this room and experience this, to pass it on in our own way, however we pass things on. And so hearing you talk about it, and we have kind of talked about this and the yoga aspect and that practice and that sort of thing. It's about integrating whatever body practice you have and whatever emotional regulation or nervous system regulation technique you have, right? So like you said, it's not one size fits all, but what you and Jeannie put together, I wish everybody could experience. It was truly like you could feel it was a palpable representation of what you're talking about.
And the other side of that coin is I didn't experience any of that at the conference. And I think that is because the conference was 2 months before my hip surgery. I was in so much pain at the conference that I hardly left our room.
She watched the conference from the TV.
I basically was like at the hotel in Philly watching the conference. I went down a few times. Now I know I was so dysregulated from within. Like, even if I had I would try, it would be like 10 minutes. I'm like, I got to get out of here. Mm-hmm. But once I went back to my place where I could regulate some, I felt better, but I had to stay there.
And so that just is an example of the whole goal. The whole goal is to get us to a place of what our normal or steady can be so that we can do the things of life that we want to do and contribute in the ways that are meaningful.
And I'm in a lot of pain now, but it's almost like I recognize it differently. And I know now what to do to get myself a little bit, like before I took a little nap on the couch and had some quiet time and had a beverage and had a little snack. Those are things I wouldn't have thought about before. I wouldn't have dedicated the 20 minutes to that. I would have stressed out about this more or tried to, and I was stressed out about this because I'm nervous because you're awesome. But just that little bit of regulation that I did for myself.
Yeah. So it's so exciting that these things that you're learning, you're spreading, but also that you're calling in professionals to be like, okay, let's all collectively try to bring our expertise together. So do you want to go to the next part?
Yes. So, we've talked about the FRS a lot. And so we know that the 7th International Fascia Research Congress is coming up this August in New Orleans. Can you tell us anything about that?
Yes, I am the Scientific Programming Committee Chair, co-chair with my colleague Kira DeConnick. So you can look up her work. She's a researcher with her own lab in the UK. And we've put together a really one-of-a-kind program with hands-on movement and practical courses from people who've submitted abstracts all the way to hard science, classic science type.
Super nerd out.
Yeah. And it's going to be this amalgamation. It's going to be a blend. And I'm telling you, it's going to be wonderful. Who knows? Who
Are you
knows?
presenting? Then yes, it will be.
I am presenting, and my colleagues will be there presenting on hypermobility research that from these studies that we've talked about. So they'll be co-presenting. And then one of my residents is coming, Rebecca Joyce, PM&R resident. She's going to help me teach a hands-on class, much like what you experienced in Philadelphia. Of course, without Jeannie, which is super sad.
Yeah.
She couldn't make it. She is on a family vacation, taking her own time and down regulating her nervous
Good
system.
for you,
like she
Jeannie.
should.
Good for you, Jeannie. You deserve it.
I love that your reach is this wide.
This Congress available for virtual attendees for people who aren't part of the society? Like, would we be able to get any type of after, either live or after, of like what was presented? I
Like
guess
presentations,
Yeah.
recordings, or whatever.
We won't have that.
Okay. Yeah.
Yeah, we're fledgling. We're a fledgling society. That's and we're growing. So there's growing pains and growing challenges, and those will help us be better. And so, yes, there is popular request and demand for on-demand recordings. And at this time, we don't have them. We will have Congress abstracts published so
Okay.
people can read through that.
Perfect.
And as we plan for the next Congress after this, we'll take these things into account. And we may even have a interim between Congress virtual type conference.
Like a symposium type thing.
Yeah.
Cool.
And all of these are in discussion and in the work. Our primary priority right now is to make sure this Congress goes off well to the
Let's
best
get past
that
this.
we can do it.
So on that note, is there anything that you wanted to talk about with us that we haven't brought up? Or do you have any questions for us?
Yes. Over the next couple months as you grow, where do you see this podcast going? What is your reach? What are your hopes, your goals?
So
As you can see, we were not expecting that question. And the episode's already been long enough, so to be continued. And I just had hip surgery, so cut a girl a break. Bye.